radiologists, we should know what is the exact location of the tumor, so that what is how the propensity to move forward, move spread. That is more important, because it is important. It is for radiological point of view, as well as the clinicians, as well as radiotherapy planning and surgical planning. So important. The staging is a very important aspect, and as well as how the method of spread, mode of spread. Okay, it can be perivascular, perineural, whatever the way. Okay, so oro-pharyngeal tumor, all of you know the staging, TNM classifications. Tumor in situ, that will be where is histological diagnosis. Tumor T1 will be less than 2 centimeter. T2 will be more than 2 centimeter, less than 4 centimeter. T3 will be more than 4 centimeter, and the tumor extension to the lingual surface of the epiglottis. The T4 will be moderately advanced, and T4A will be further divided into 4A and 4B. 4A will be maybe involve the local disease, the larynx involvement, and extrinsic muscle of the tongue involvement, medial pterygoid, hard palate, and mandible involvement. Whereas very advanced stage 4B consider when we involvement of the lateral pterygoid muscle, pterygoid plates, and nasopharyngeal involvement skull base. Why it is important? Because it may be the spread of the lesions. Okay, the management depends on the staging. Okay, almost around 40% the early diagnosis with T1 and T2 with the nodal 0 will be single modality of treatment. There will be only surgery or maybe RT. Okay, so that laser treatment can occur. Or whereas around 50% is slightly advanced. We get T3 and T4. We have this chemoradiation and surgery. Okay, and the 5% there will be moderate advance, and maybe a metastatic process would be whether M1 or R1 may be involved. Here palliative and chemotherapy. All of you know this one. This will be important for making diagnosis and treatment planning and treatment strategy. So epidemiology in oral cancer, all of you know this will be in India. I'm statistics there are around 10 to 1 million population, and this will be buccal mucosa will be most commonest site, and squamous cell carcinomas 95%, 91%. Adenoid cystic carcinoma will be less than that one. This is more costly will be Uttar Pradesh and Bihar, northeastern part, because the most involvement. Major risk factor will be two things important thing. One is smoking and tobacco and betel chewing and alcohol consumptions. And HPV infection will be around 30% in the population of India, whereas northeastern possibly more than that one. A lot of prevention strategy is going on in India by the tobacco cessation, HPV vaccination, and oral cancer screening. So HPV related SPV, because usually common in younger age group, oro-pharyngeal anatomical site will be usually around 80%. Okay, here the primary tumor very small and nodal extension, usually non-keratinized, will be very good prognosis as compared to the other smoking related oral cancer. Oro-pharyngeal cancer will be different subset. We have to should understand. Oropharynx will be tongue base around 43%, along with the tonsil and palatine tonsil and soft palate involvement around 45%. Oral cavity around 11%. Whether here buccal space, that mobile tongue involvement, hard palate, retromolar trigone, flora mouth. So this subset of the oropharyngeal cancer we should be familiar. Okay, oropharynx consists of three subsets: base of tongue, lingual tonsil, and palatine tonsil. This is the area where the tumor here, the spread, okay, in the soft palate is from the oropharynx. It goes spread in the soft palate superiorly, and involvement of extension to posterior lateral pharyngeal wall in the laterally, and anterior-inferiorly and anterior-inferior extension glossotonsillar pillar tongue, and there is a posterior inferior extension into the hypopharynx. This is the area where it can spread. Okay, the lateral extension into the parapharyngeal space. Nodal will be usually grade level 1 to level 5. Ipsilateral node around, this is statistically around 55 to 70%. Contralateral side will be 13%. So this is an example of the spread of the oropharynx. This will usually be tongue base, will be usually circumpapilla involvement, because most often it will be very, very identified in imaging. Okay, these all will be you need about other modality like a PET scan. Yeah, because it is a very, very commonest way, unknown primary can get. So tongue-based involvement can involve the muscles of the intrinsic muscle of the tongue. Okay. Here is an example of the tongue muscle involvement, intrinsic muscle of the superior longitudinal muscle and inferior longitudinal muscles with the transverse muscle involvement. This is tongue-based involvement. Here, again, there will be involvement of the shape of the tongue will be altered. Okay, the tongue-based involvement. Whether the extrinsic muscle involvement, they can get in the advanced stage. Okay. Tonsils, okay, that is a lingual tonsil. Okay, very, very commonest one will be very unknown primary. Whenever the metastatic process, you get unknown primary because of the porous membrane involvement and propensity to small carcinoma to metastasis. So you may not see in the imaging finding. Imaging can be often will be hidden. So these are whenever you see unknown metastasis, you have to think of the lingual tonsil. Here is the example of the case, such case, because involvement of the lingual tonsil with involvement around this will be detected by only in PET scan. Okay. Here is a PET scan, it will show positive and the base of tongue and lingual tonsil involvement. And this is next the lingual tonsil. There's no other lingual tonsils, and apart from lingual tonsil, you can involvement of the anterior tonsillar pillar or posterior tonsillar pillar and the palatine tonsil. It can go spread along the buccal space or posterolaterally can extend involvement of the masticator space and medially involve the hypopharynx and so on. So this is a case where infiltrated lesion in the lingual tonsil with involvement of the lateral side wall of the. So here is another example of the lingual tonsil involvement of the parapharyngeal space with the pterygomandibular raphe involvement, because it is go all along the pterygomandibular raphe anteriorly and involvement. Okay. So when you see that this location, the extent, this propensity to go in buccal space or maybe retromolar trigone or posterior parapharyngeal space or maybe posterior in the hypopharynx level or maybe in the posterior perivitral space. Palatine tonsil involvement, the other one palatine tonsil is the example of palatine tonsil can extension into the superiorly involvement of the palate, short palate involvement or retromolar trigone involvement, like a retromolar trigone involvement, or it can involve a pterygoid muscle. They all will be spread along this pathway. Okay. Once you see this imaging, you are look for this particular areas. Why it is important? Because sometimes it can go involve the perineural spread or perivascular involvement, or sometimes very advanced case nodal involvement can extranodal invasions can into the vascular channels. Here is a patient with there is such a tonsil involvement, lingual tonsil, but here the important areas involvement is a superior constrictor. The superior constrictor is one of the topmost priority you should look for, and specifically for why superior constrictor is often invasion, high chances of infiltration. It can lead to poor prognosis. This study has shown superior constrictor muscle infiltrated less, the survival rate will be less than that of the non-infiltrated case. So this information is important for clinicians. You have to look for the superior constrictor involvement. Here look at this normal area and the superior constrictor involvement here. See, this is a patient with lingual tonsil involvement, early changes, and this will be easily be mistaken as a normal areas. After 6 months, so this patient having there is extension into the tongue muscle and intrinsic tongue muscle involvement and involvement of the lesion involved in the hard palate, short palate, and that involvement of the necrotic areas, and slowly it is extended into after 6 months it goes into the perineurally into the foramen ovale, and it is going into the intracranially extension of the parietal gutter. So this perineal spread, if you miss the lesion in the earlier stage, you can, if you not miss the stage, that one, this is a minefield for radiology community, particularly if you see. This is a patient, same patient I showed, there's no involvement of the masticator space involvement, pterygopalatine fossa involvement, B2 and the median canal involvement. So this extension is important. Sometimes it can directly involve the carotid space and the involvement of the carotid canal. Next, short palate. Take this next subset of short palate involvement. Here the patient having short palate, it can involve the palate involvement. The palate involvement, it can involve the entire superior aspect of palate. Once the palate involvement, it is prone to through palatine canal. Palatine, it is called the palatine nerve. The entire palate may be involved, It may extend involve the muscles, muscles, the levator valley palatine muscle and tensor palatine muscle. So this becomes stage 3, stage 4A and 4B. Why it is important? It is functionally is important because once this out palate involvement can affect the Oro-pharyngeal mechanism, resulting in aspiration and during swallowing a functional impairment can occur. So this information is important for clinicians to look for this functional impairment if involvement of the muscles, particularly the levator palatine muscles and levator palatine teres. So next one is the oral cavity, buccal space involvement. Buccal space, clinically, we can see clinically, you can see the lingual, that areas of alveolar process involvement or early involvement, the alveolar gingival sulcus areas can producing the areas lesions with the advanced case. It can extend inferiorly or maybe it can go superiorly. Here is a patient with the squamous cell carcinoma involvement of the alveolar process with the early node, and sometimes it can, advanced case can erode the bone, cortical bone with the mandibular nerve involvement. Okay. So whenever see buccal carcinomas, you should look for areas actually with, there is a typical technique called puffed cheek technique. So when we see this technique, you can see the very early stage of buccal carcinomas as we see in this particular case. Very subtle case, the early changes, we can make it with the puffed cheek technique. Here is a post-operative patients, post-treatment case of carcinoma buccal mucosa with retromolar trigone involvement. This patient underwent a treatment with hemimanectomy with the flap reconstruction, followed with image. So based one with the FDG PET shows there is a buccal space involvement. Okay, buccal space nodal thickening. So the disease progression can be picked up by with this maybe PET imaging or maybe CT scan with the MR technique also. Tongue, mobile tongue, we can look for. We see the mobile tongue, that is anterior part of the tongue. Can does the tumor cross the midline? Whether involvement of the oral tongue involvement or base of the tongue involvement. It can go anterior 1/3, anterior 2/3 and posterior 1/3, or whether involvement of the muscle involvement, whether mandibular invasions. The tumor extends the sublingual space, whether it is going to the sublingual space, extend the Watten's duct involvement. So these information you have to look for specifically. So apart from this one, you can see that nodal status will be level 1 and level 2, and ipsilateral 60% of the node can occur. Condylate node will be 8% according to the literature. So we should look for these areas. So here is the example of early subtle changes of the involvement of the early carcinoma. You will be missed the lesions in the CT examination. So we do MRI, and MRI picked up the lesion. Sometimes because dental artifact you cannot get. So in this situation you need about a PET imaging. If you do a PET imaging, you can demonstrate a subtle enhancing lesions and with the avoiding the beam hardening artifact, these hypermetabolic areas. Here the patient having entire involvement, intrinsic muscle involvement. This is a necrotic mass in the intrinsic muscle involvement can occur in adenoid cystic carcinoma. Whereas a tumor in the squamous cell carcinoma involve the surface lesions can infiltrate in the deep muscles and the reverse way. Okay. Here is the muscle involvement of the tongue muscle can. So if the lesion is anterior to third, involve the genioglast muscle without involvement of the hypoglossal muscle, whereas the posterior third will be usually hypoglossal muscle involvement without involvement of the genioglast muscle. So these are all can, if we involve the entire areas, the deep muscle involvement, hypoglossal muscle involvement, it is very classical T4 involvement. So carcinoma of the tongue can occur, sometimes will be subtle in the case, sometimes it will be like a ductal involvement. A carcinoma tongue will be with infiltration of the ductal system. Once you do a CT, cannot demonstrate very well clearly. If you do this, same patient underwent PET imaging. PET imaging shows increased uptake. So these lesions can occur in the sublingual space, sometimes it can extend anteriorly and involve the alveolar process. Anyway, it can spread this way. Sometimes it can involve the alveolar process and mandibular involvement in advanced cases. Coming to the other oral, anterolaterally involve the tongue, it can involve the crossing the midline because it is important for to staging of the disease, whether involvement of the flora of the mouth, base of the tongue, or glossotonsillar sulcus involvement. Here is the example of the patient having there is small lesions with a large metastatic node, hypermetabolic node in the level 2 nodes, with there is infiltration to the adjacent close to the vessels. Okay, this is it, say the T2N2B. So coming hard palate can involve the hard palate can involvement of the, it can go anteriorly and involvement of the palate, Once the palate involvement can perineal spread, there is a high chance of perineal spread by through the greater palatine canal. As the spread occurs along the palate nerve is going to the greater palatine nerve. Then from the PDN nerve, we can go to the anteriorly or maybe V2 involvement. So this information very vital for a particularly radiotherapy planning. Okay, the last one, retromolar trigone involvement. The trigone involvement here, the spread can all along posteriorly or anteriorly buccal space involvement, or maybe look at retromolar trigone involvement of the oral cavity and oropharynx, and as in this case, or carcinoma retromolar trigone can metastasis and alveolar process. This last part will be flora of the mouth. It will be can involve the flora sublingual space. It is most common. Sometimes involvement of the mandible, as in this case, with infiltration to the adjacent nodal status. So flora of the mouth can commonly come across in some cases. So the predetermined pathway helps to predict the disease spread, design the surgical plan, especially the management of the early cancer, so that it will be easily to depict the lesions and give them to the radiotherapy planning. CT is preferred modality, the oro-pharyngeal case, but MRI will be more sensitive and can get more involvement of the areas of involvement, particularly perineal spread, perivascular space. PET imaging, base of the tongue, patient with the denture, systemic M stage and post-treatment surveillance, PET imaging. MRI is a complementary problem-solving modality, in particular diffusion, dynamic T1 perfusion. With the lack of time, I would not show the dynamic T1 perfusion, particularly base of the tongue, skull-based lesion, and perineal spread. This MRI technique will be very useful. Thank you very much for your attention.